All right, Veronica, we are back with another one, episode 4. I can't believe we have hit episode 4. So, welcome to the Survey Readiness Podcast. I am your host, Dr. Kirk, and joining me is my fabulous co-host, Miss Veronica Caesar, VP of Clinical Reimbursement.
Thank you, Dr. Kirk. Each episode, we will break down the regulations that facilities are being cited under, the FTAGs behind them, and the plans of corrections that organizations submit to get back into compliance.
Now, Veronica, we're dedicated to quality compliance, and with that, this podcast is dedicated to that as well, right? Helping post-acute care organizations, helping post-acute care leaders understand survey readiness, the way that it actually works, not the way that we think it should work. So, we try to do this every 2 weeks, but we are working professionals, right? I mean, you've been on a grind doing speaking engagements. I'm trying to push SurveyGuard forward. So what we can commit to is, right, when we do meet every 2 weeks, we're going to review real CMS 2567s, review real findings, talk about leadership, compliance failures, and survey preparation myths that continue to get us cited.
Right. And so each episode we focus on a specific citation. And so I'll walk through the FTAG we're reviewing today. We'll explain the regulation behind it, and then we'll break down a real plan of correction so leaders can understand what surveyors expect to see.
Now, if you know me, I'm opinionated. We promise to be as educational as we can, but this is our opinions, right? So this does not constitute legal advice, constitute us being hired as your consultants. This is just our opinions, based on the facts that we read it at the time and based on CMS rules and regulations. But we can't promise to always be honest and grounded in reality.
So if you are an administrator, a compliance officer, a director of nursing, an owner, regional leader, we're really trying to help prepare you to respond earlier. That way, respond to citations the right way. If you're looking for that, you guys are definitely in the right place.
Facts. So this week, it's just like the rest, right? We got a POC, we got an FTAG. Veronica, tell us what we're talking about today.
Today, we are talking about FTAG 575 and FTAG 579. They go hand in hand. And so 575 is our resident notices and rights. And then our F579 is our required postings.
Yes. And I think it's important. So let's dive into it. Veronica, you've been super busy. You just got off of stage doing yet another keynote. Where were you at recently? Tell us about it.
I had the privilege of speaking at Iowa Healthcare Association last week, and they had their greatest turnout. Over 400 long-term care, assisted living professionals showed out. I mean, the education sessions were amazing. I not only presented, but I attended some sessions. They had great leadership tracks. They actually had assisted living tracks, but not just leadership for, your administrators, DONs. I interacted with activity professionals, with new DONs, with the whole spectrum of the IDT team. And so I had an amazing time. Thank you to the folks at Iowa Healthcare Association for your hospitality. It was really a great week.
And I'm just getting back from a packing where we debuted SurveyGuard. This is the second event, and it was amazing feedback. It was actually very remarkable to get the feedback from the people, right? And, what people loved most, of course, about SurveyGuard is plan of correction writer, right? We can write 35 tags, give them an audit in under 5 minutes, but just the fact that it's an all-in-one system. So I didn't speak at this event. It was a strategic decision to focus more on the product, but, plenty more speaking coming down the pipeline. I'm sure you're speaking. Where you at next?
I will be at Oregon Healthcare Association, the great state of Oregon. I am speaking there on April 23rd. I'm actually speaking about pain and dementia, behavior care planning, and documentation, defensible documentation.
So if you don't know a little bit about me, if you just stumbled across this podcast and you've been living under a rock and don't know who we are, my name is Dr. Demetrius Kirk. I'm a registered nurse, a licensed nurse home administrator. I've served in every role from CNA to LP and RN. everything that you can think. I've been a janitor when the cook didn't call in. When the cook called in, I was the cook. I've been the driver of the bus. I have my chauffeur's license. I mean, I've done it all. But that's a little
Yeah.
bit about me. That's just ground you in who we are. So when you hear us speaking, we're not just speaking, for like some of these other people, right? They're talking, but they've never been in those role, right? And Veronica, you in the same, boat. Tell them about your experience and who you are.
CNA to LPN to RN, DON, licensed nursing home administrator as well. I'm currently serving in a VP of clinical reimbursement role. But again, like you said, working as I also oversee, I worked as a social service designee. So some of the stuff we're going to talk about today is stuff that I had to deal with. So it's definitely, when you say every point in the building, I've definitely done that as well. We definitely have put in the work. So we are speaking from real life examples, not from an office. Both of us are in offices now, but we've been in the trenches. So we understand what you guys are going through and the real no nonsense information you need to be survey ready.
Let's talk about it. So before we dive into it, we have three sponsors that make these episodes possible every 2 weeks. Let's bring them up on the screen. Thank you to Survey Guard. This is the post-acute care compliance platform of choice. SMK Medical, if you don't know, that is my healthcare consulting firm. We specialize in risk and compliance. We are known for our mock surveys. We do so many mock surveys. We've trademarked the word mocksurvey.com. And we actually own the domain mocksurvey.com. And Jim Healthcare Consulting. That is Veronica's consulting company, where she focuses on education training. That's where she does her speaking engagements and things like that. So I appreciate it. I didn't see any new QSO memos this week.
No.
They kept it quiet. So let's dive right into that F tag. Let me put our little graphic on the screen real quick. So let's talk about it. While you're talking about it, I'm going to get our screen up on it. But what F tag are we focusing on this week?
So we have our F757, which are our required postings. And so things like resident rights, complaint and grievance contacts, your survey results access, ombudsman information. So these should be posted in common areas in an easily readable format and appropriate language. And then F tag 579, which usually goes hand in hand with that, is our Medicare, Medicaid, and admission information. So we want to make sure our residents and their families informed about Medicare and Medicaid benefits, covered versus non-covered service abilities, and then making sure that they are notified of changes timely.
Yeah, and so to your point, right? What I have on the screen, got to make it smaller, right? You're going to talk about it from the a plan of correction, because there was an actual plan of correction that was cited. But when we talk about F575, right? Mandatory posting. This is an easy tag that I think people miss, right? And when I think about mandatory posting, you raise your head. You got some experience with missing some mandatory postings?
I actually had this happen this year. So we did not have 3 years of survey results posted. I believe it was one
Easy
year.
tag.
One
Easy
year was
tag.
posted. So yes, something
Administrators,
so easy.
it is so right. So when I do a mock survey, I know to go check for those mandatory postings, because people will take them off the wall and take the posting down because they're cleaning something and forget to put it up. Housekeeping and move things they don't think is important. Maybe the sheet looks old, discolored, and stained. So then they take it down thinking they're doing you a favor, but ultimately it's actually hurting you. So when we talk about the requirements, right? You have to have the government agencies posted, right? Long-term care ombudsman, how to file a complaint. You gotta have it there at a eye level one, so eye level so the person can read it, at a font that so a person can read it, and it has to be there. So that should be a part of your survey readiness plan, is to make sure that those things are there. As you mentioned, 3 years of look back, right?
Yes.
I've seen large POCs that are 150, 200 page, and then so they try to split it up, but they have version 2 locked in an administrator's office. It's okay if you say, see the front desk to get this
Yeah.
information,
Right.
but you can't have it locked where people can't see it. And so when we talk about a conspicuous physical location, it needs to be out and open. It can't be in a dining room where it's locked and people can't see it. If I walk into your front office, into your vestibule, I should be able to see this information. What are your thoughts?
Exactly. And that's a great point when you said about making sure you're looking at if it has all 3 years, right? So we
Yeah.
assumed that we had the posting. I'm not sure who was the last person to actually visualize each year, right? And so
Yeah.
that's a very important topic. Don't just assume because you see the binder or you see the book or whatever
Yeah.
mechanism you're using to post these survey results, that if you see pages there, are they the accurate, up to date recent survey, right? Who is responsible? That accountability piece, who is
Mhm.
responsible for updating that book as we receive new surveys, right? New survey results. So that's definitely something very important and often overlooked.
Uh, Facts. And so, that leads us to, what else we were talking about when we talk about the 579, right? And to me, all of this stuff kind of go hand in hand.
Mm-hmm.
Patients have to be informed of their rights, right? And you can do it in writing and you can do it orally. And I think what happens is, you know, we think we are telling people, right? So when you think about the rights to apply, and you have a plan of correction, we will get to, but you think you've told a patient, but ultimately, if it's not documented, it's not done. So it goes a little step farther to, hey, yes, you have it posted, but how are they informed? Because just because it's posted doesn't mean a resident can read.
Right. Right.
Just
Yes.
say it. So orally and in writing, and then accessible formats, right? So when we think about accessible formats, well, it's there for them to see. But as I called out, what if they speak braille? What if they're blind, right? Do we have it? Do we have it available to them? Or large print? 12 font doesn't work for everybody. Let me take
Right.
off my glasses, baby. 12 font is not working. But what if they speak another language?
Right.
What are we doing there? So, how are we making sure that we are giving the residents what they need, and ensuring that these easy citations are not being cited? So, as you follow this round, right, orally and in writing, accessible formats, paying language, and then notifying them of their legal rights. We put it in that contract. We bury their rights and responsibilities in that contract. But when are we educating them on it?
Right.
You issue them a cut letter, which you issue them a cut letter, and you think they know, oh, you have a right to appeal. So, UVP of reimbursement, how do you handle that? How do you make sure one, and patients are informed of their rights, so you're not getting this easy citation, right? Because yes, it's posted, but you told me that when I entered the building or when I signed an admission contract. How are you making sure that you don't get these easy citations moving forward?
Exactly. So documentation and training to whoever is responsible for issuing that NOMNIC. Another required notice could be that advanced beneficiary notice. So if you have those
Ooh.
skilled patients who are remaining in your building and they still have days to use, if they decide to continue on after we say that they could possibly incur, a bill for that. So making sure that we are explaining that. So we've done extensive training with our social service, our business office staff regarding those specific required notices, as well as identifying those patients early who may need assistance in applying for Medicaid, right?
Mm-hmm.
What is your
Mm-hmm.
what is your discharge goal? What is reasonable? Will you be able to leave if your skill stay is 27 days, right? Do
Mm-hmm.
you have assistance at home? Are you maybe possibly thinking about staying long term? Because then we have to start that process. Because a lot of times what happens is they're cut. The next day we say, okay, you got 2 days, and then you're gonna be responsible for billing,
Yep.
and then that resident doesn't understand even what's involved in a Medicaid process, even if they would be eligible for Medicaid. Now we're asking them for 3 months bank statements, and they've been in here for the last
Yep.
27 days. Is it accessible for them? So making sure that we discuss this at length and in detail very early in the stay.
Now I'm digging a little bit over into that plan of correction that you're gonna bring up and kind of walk us through. But before we go into that, we're going to talk about it, right? Because we educate patients at admissions, right? 100% admissions at educate them 100% at admission, and then what we see here is this kind of drop off, right? Where now the forms are visible, right? So we did it. We were great. Everybody got education, but then we expect them to go to that front lobby to remember something 2 years down the line, right? And then after that, we go to, as you talk about in the POC, right? Now we want them to translate that knowledge to, oh, I have rights. Let me call and get assistance, right? It don't happen that way. It's not
Mm-mm.
happening that way. So, you have a plan of correction that you're going to walk us through. Let me find that POC really quickly. You have a plan of correction that you're going to walk us through. I'm going to bring that over here. Talk to us about this plan of correction here. This is a real life plan of corrections. I'm not affiliated with this building. We just picked this plan of correction because we picked this plan of correction. We leave it at that. But talk to us. This is the actual 579. What happened here?
So this resident was admitted to the facility. They were receiving skilled services, and so if you're looking at the plan of correction on the screen, they admitted on 11/20/24. Their diagnosis included COPD with respiratory failure with hypoxia, and then also post traumatic stress disorder, and they discharged on 4/2/25. Review of the notice adverse determination, so that they looked at the nomic dated 3/28/25 revealed that the resident no longer met the skill level of care, right? And then their needs could be met in a lower level of care. That could have been custodial care, home health, whatever, but not the need of a skilled nursing facility. And so what happened is of course, the nomic has your appeal rights, the way to file a grievance, all that stuff. But so the surveyors actually reviewed the progress notes from the social service, which was dated 4/1, the day before the discharge. It was
Every
dated
time.
4/1, but it was actually created on 4/2, so they backdated the note. And so on the note, it said that the director of nursing spoke with this resident about an immediate discharge due to non-payment. And so
Where was the
again,
plan? Where was the plan?
we just talked about that, right? And so this person admitted in November, right? And so this discharge happened in April. So that's literally 4.5 months of ongoing planning, the opportunity for ongoing planning. And so they did look at, let me pull that up.
Sorry, I got to bring that back
No, it's
up.
okay. I got it up on my screen so you can change what
There
you
you
need
go.
to change. But they did
Yep.
look at um, the most recent MDS. So the resident had a BIM score that showed that they did not have any cognitive impairments, and they had coded this discharge as unplanned on the discharge MDS. So surveyors then interviewed the business office manager, who confirmed that the resident was a skilled care. Actually, this was in Ohio, so they do have skilled Medicaid payers, and so it's skilled through Medicaid, right? So they have a long-term care Medicaid and a skilled Medicaid program. So this patient was actually skilled under their skilled Medicaid payer, but that, of course, they operate just like a managed insurance company, and so they have to have authorizations. And so the managed Medicaid, the skilled Medicaid, contacted the facility and said that the resident no longer met that skill level of care. Okay, and so the BOM then verified that the facility did have an opportunity to assist the resident in applying for long-term Medicaid services, but did not do so. They were unable to um, um, say why they did not do so, right? And so then they talked again with the business office, and she verified that the facility did not provide the resident the opportunity to apply for long-term Medicaid. Then they called this resident, right? They called the resident 2 months later. This is the survey 2 months later. They called the resident at home. And of course, she verified that she was not given the opportunity or assistance to apply for long-term care Medicaid. And then so they did pull up a policy. They're always going to ask for your policy, right? So they pulled up the policy. They had a policy titled Transfer and Discharge from 10/17/22, and it revealed that a facility initiated transfer or discharge was a transfer or discharge to which the resident's objects the, to which the resident objects or did not originate through a resident's verbal or written request, right? And so the facility would not initiate the discharge of a resident based solely on the resident's payment source or change in the resident's payment source. So now they're not even following their own policy, right?
So, and so what I have on the screen is an example, right? We have passive administration, right? Failure to use facility resources, failure to follow their own policy and procedure, right? To establish a safety net for transitioning for payment sources or payment reasoning. This is kind of a fishbone, right? So then we have
Hmm.
a broken workflow. We didn't have EHR triggers to notify social services when the resident private funds was depleting, whether that's BOM or whoever, and then staff competency, right? Administration, clinical staff viewing financial status as a billing issue rather than a fundamental resident right. And then it led to 579. I mean, that's how it broke down, and this is how it happens every single day. So we, as here on the Survey Readiness podcast, we're not just hypothetically talking about something. This is a real citation. This is a building that really received a citation for something that could have been avoided, and this is the importance of having systems, processes, and people in place. And this is why we must continue to train, and this is why we push this Survey Readiness podcast forward. um I've been tagged for similar things when I go into a nursing home. So this is not a slide to anybody, right? These things will happen, but financial advocacy is not a billing courtesy. It's a
Yeah.
clinical imperative. Leadership
Yes.
must provide equal access to quality care regardless of payments.
Yes. Have to.
It's it's
And
easy to
then
say issue.
especially the like you talked about these admission agreements. You
Yeah.
come in, you've been in the hospital a month, 2 weeks, and they've shoved this admission agreement, and now they're making them more electronic, so you can go skip to the place where you are required to sign. So are they
Mm.
really reading 40 pages, right? So it's just important to make sure that we understand signing a paper is not the same as understanding it. And so we have a
I-
duty to make sure that they're understanding what we're providing, what this agreement is covering.
So what you're talking about here is exactly what you just said, right? We bury the forms in 40 pages of admission documents. It's a passive system, right? Instead
Right.
of being highly visible, multilingual, making sure that audits are done, people understand what they're signing. Because when you said these advances to technology or these advancements to technology are amazing. It takes you right to where you need to sign. But if I skipped over my rights, you possibly can get cited for that, right? Waiting for families to ask about Medicare and Medicaid when you should be proactively saying, "Hey, we have 60 days out. You should probably think about how we're going to fund this afterwards," and then document it. You had a care plan meeting, an
Hmm.
IDT meeting, and then
Hmm.
you documented it, right?
Yes.
And
Yes.
then what happens is when we ignore retrospective ineligibility until the family complains, well, it's kind of too late now. They've complained and they kind of have a point. So how are we going to fix this, right? How are we going to proactively refund it if Medicaid kicks in? Maybe they found a private payer, right? You don't get to keep two funds. You don't get to keep Medicaid's money and the family's money. You don't get to
Right.
do that, right? So we
Right.
have to be proactive in the way that we manage that forward. So, um, broken care. We have the three pillars: environmental visibility, processing, hardwire, and then culture. Adequate access for all. Um, it's simple, and I know I can say it's simple here sitting on the podcast, but really, as the leadership in the post acute care space, it's our responsibility. I mean,
Hmm.
do you think otherwise, or what's your thoughts, Veronica?
No, it's definitely our responsibility. And it's just education. I feel like a lot of times our staff want to do the right thing, but
Yeah.
we have to educate, continue to educate. And we talk about, staff retention. So if you have a new BOM in your
Ooh.
building every 3 months, we're going to have to make sure that she has that education, every new person, right? Or, just making sure. I'm speaking in Oklahoma in May about competency training, making sure that it's
Mhm.
specialized to your facility. And so a lot of time we just think about competency as CNAs, doing the CNA
Yep.
checkoffs or doing the nurse checkoffs. But if we have a population of residents where we have a lot of Medicaid pending, or we may have a lot of
Facts.
residents who are unsafe discharges, do we need to then include BOM competencies, right? So a lot of time we just think of clinical staff. And so we just really need to look at the wide scope of all of our staff, and then what the population we're serving. And that all can tie back to your facility assessment. I love the facility assessment.
Hey, listen, so that's a good spot for us to once again thank our sponsors, SurveyGuard, who has a facility assessment built in, quality management program built in, mock survey prep program built in. So if you're using our survey prep module to prep for survey, it will check for those required postings for you. How about that for survey readiness, right? Telling you where to check and what to do, right? And then if you
Yes.
need that additional on-site training and education, there's SMK Medical. We actually come on site and do training education. Then we got Gym Scout. I talk about what you do, Veronica, but tell them more about what it is your company do.
I'm doing a lot of educational trainings. I'm no longer consulting with long-term care facilities individually, and so I did go in and do the same thing that SMK does, doing the mock surveys, doing quality measure improvement programs. But I have focused my efforts on MDS people who don't have
Yes.
resources to find out about QMs. A lot of times we have MDS people who are, okay, we need somebody, we'll train you. And maybe their training was like me back in 2008, one day, click, click, click. And so I'm that person who can be a resource to, any member of the IDT team. So I talk
Yes.
about activity. I talk about social service. I do care plan training for the IDT team. I'm currently building an MDS basics course for new MDS nurses, for nurses interested in getting into MDS. And so I'm more focused on the individual training. I do offer leadership training as well. I know you do too. But so yeah, I'm focused on that person who wants MDS people. Every MDS person I've met wants to do the best job they can, and so just giving them that support to go from stressed to strategic.
Man, that's what's up. Okay, I
I
love that.
like that. I like that.
Let's hey, listen. I got a host everyone to do when I'm acting like I'm doing something. Let me do this. Put a little type in there. I got this one. Let me show you this other one. Stop the typing. Let's see if I can get this one working. That one. When we drop in fire, and then we need to start dropping that one with the F tags.
With that tag, I
Let's
like that. Yes.
let's talk about it, right? So we want to give you something this week, right? And this is our compliance checklist for F575 and F579. So me and Veronica, we put this together, and ultimately, surveyors are going to come in and they're going to check for required postings. So what we did was put together a list of all the required postings you need to have in your building. We even helped you categorize it by high, medium, and low. Of course, it has our survey readiness podcast on here. But as you come down here to satisfy F7575, right, do you have your APS documentation, your state long-term care ombudsman, any HCBS information, the Medicare fraud unit, right? We kind of walk you through what that looks like, your arbitration agreements, if you're using them, right, posted in admissions, and making sure that they're in the appropriate places that they need to be. As always, this is for educational purposes, right? It is designed for you, but it's also meant for you to utilize it and put in place where you need to put things in place. Minimum wage notice, elder justice acts, all of that good stuff that you need here. So we have this here for you. And it is available on all socials. As with this podcast here, we talk about what the surveyors are going to verify and what get facilities cited. Think that's the gist of it. Veronica, do you have any thoughts on this here?
I love this, and this is actionable, right? We know it's a lot of steps in this, right? Maybe steps that somebody listening or watching may not have even known about. But I love the fact that it is prioritized with high and medium low. And so you start with your high impact areas, right? And so we know you're not
Yep.
going to do this one day. You're going to go back to work tomorrow and say, I'm going to put all these up in one day, but making sure that you start with those high impact areas. This also
Yep.
can be another tool to inform your training, right? Do
Mm-hmm.
the people responsible for these things know about these things, right? So not only is this a checklist for making sure that you have the proof and documentation, but you can also use this as a training checklist to make sure that do we have somebody who we have designated for this? I find a lot of gaps and failures happen is because people assume somebody else is doing it. The administrator should be doing that. The receptionist is responsible for that. Social services. So just making sure that we have a designated person, that everyone understands who that designated person is, and then making sure they have that training available to be successful.
Hey, you're 100% right on that. I have something scrolling across the screen, right? As we draw this to a close, right? We always want people to drop it in the comments. I saw a total of 5 people watching this live, which is great, right? Because we just kind of go in. We need to get a consistent time. We're working on it. With you being extremely busy, me launching Survey Guard, we're just trying to make it work. But we
And
are
the
putting
time
it together.
difference,
And a 5 hour time difference. So it's 11 o'clock in the morning here. What time is it where you at?
4:30
See.
p.m.
See?
in the evening.
So, but I know we talked about it. What we want to do is we want people to we want guests, right? We want you to come on here, talk about how you get survey ready as a leader, what you're doing, which strategies you're doing. Maybe you have a 5 star facility and you want to share with us some tips, tricks. We want to get that out to the masses. So if you have that 5 star facility, 4 star, 3 star, 2 star, 1 star, we want to talk to you because everybody has a different element of what they're doing to get survey ready. So we don't want it just to be our opinions, our thoughts. We want you to, come on board with us and share with us. So, Veronica, I appreciate you. How can they reach you?
They can reach me at veronicacaesar.com. If you'd like to email me, you can email me at veronica@veronicacaesar.com.
Hey, visit that website. You got a couple ebooks up there that they need to check out. You
I
have
do have a
some
survey
leadership
readiness
stuff.
ebook,
I'm just saying.
and it's
Listen,
free.
they need to get it right. So, one of the things I love is leadership. I love compliance. I love risk management. I love strategy. So, this podcast is in collaboration with, the various, people we've stated, right? SMK Medical, Survey Guard, Jim Healthcare Consultants. And we just appreciate you for vibing with us, right? We're going to continue to do this. We're going to continue to put it out. You were at an event with me, Oklahoma, where people came up to us and said, "Hey, we listened to your podcast." So,
Yes. And they definitely gave us their feedback.
yes, yes, yes. So if this episode helped you think differently, prepare earlier, hit that like, subscribe button. We love for you to share it with your leadership team, share it with your regional team, and join us for the next episode. You can always follow us at the Survey Readiness Podcast. You can follow me on Instagram, TikTok at your healthcare consultant. You got an Instagram, TikTok?
No.
Oh well, I understand. Me, I'm very vocal on my Instagram and TikTok because I work for myself. So,
It's a generational thing,
I, so until next time, we want you to stay survey ready. Thank you, everyone.